Chemo, the most common form of cancer treatment. Let's go straight to our nursing responsibility. We won't test you on chemo because, let me put it this way. You're not going to get chemo specific questions because we are not right. You need a BSN and additional schooling in order to get chemo certified, which doesn't happen in the first 12 months of the year. Remember, NCLEX will only test you entry-level knowledge, not as a experienced nurse. Clear? All right. And again, for chemotherapy, that means it has to be you need to be certified to give it. However, the responsibility of taking care of patients receiving chemotherapy falls on every nurse. Do you have any questions about that? You can take care of a patient receiving chemo, but you're not giving the chemo drug. Is that clear? Yeah. Right. So you still need to know what is my responsibility when a patient comes in receiving chemo. Okay. So the idea in chemo is we give it intravenously, orally, intrathecally, intraosseously, intravesicularly. So many routes of giving the chemo drug. All they have in common is they will be absorbed by the cells and they will kill the cells. There are many types of chemo drugs. They target different steps or phases in the cell division cycle, meaning during mitosis. So that some of them will kill it during DNA replication or during whatever phase. Okay, but what do they have? What they do have in common is they will kill and target rapidly dividing cells, which is the characteristic of cancer. So we'll skip this part. You do need to know the names though, because how will you answer the question if you don't know, oh, I didn't know that was a chemo drug. Does that make sense? Only the name. You need to be able to recognize the name because the NCLEX question won't say, a patient is receiving vinblastine, a chemo agent used to treat breast cancer. No, it will just say, a client is receiving vinblastine. Which of the following will the patient monitor? All right. So they won't tell you what that drug is. You're expected to know that vinblastine is a chemo agent. Make sense? Okay. But the question again, the question won't be about vinblastine. Like what is its mechanism of action, blah, blah, blah. Nothing like that. Because what do all of these chemo drugs do again? They kill rapidly dividing cells. Okay, they do not distinguish. You're rapidly dividing cells, I'll kill you. Does that make sense? Okay, so it doesn't distinguish whether it's your hair cells, whether it's your bone marrow, whether it's your GI tract cells, or whether it's a tumor cell. You're rapidly dividing, I'll kill you. All right? Okay. Just so happens that chemo drugs are rapidly dividing, so they get killed. So the chemo drug works. So these are the names. There's no table. There is a table. Okay, right here. Table 12-7. Because otherwise I thought we had to look at each paragraph for the names. Okay, like these, they should be on that table, 12-7. Okay. We'll skip through the dosing because we're not giving them. Okay, so let's start here. Extravasation. How it works is, let's say you're a entry-level nurse. So Tenzing, I'm Tenzing. And then the chemo certified nurse is Yannick. So Tenzing is not certified for chemo. She'll call Yannick. Okay, Yannick works on another unit. She just happens to have a chemo certification. So she gets additional hourly pay for having that certification. She doesn't have to perform that job every day. She'll just be on call. Okay, so we'll call you, hey, Yannick, you have chemo certification. Tenzing will ask her, okay, can you give this for me? Sure. She'll come down. She'll report off her patients while she's down to help Tenzing's patient. So oh, hey, here's my report. I have to go down. Okay, so she comes down, takes care of Tenzing's patient for a few minutes. So she'll simply administer the chemo. So she'll do her pre-administration assessments, take vital signs, educate the patient, and then hang the chemo drug. And then she'll give specific instructions to Tenzing. Okay, call me if these happen. And if this happens, this is what you do. All right. One of those instructions will be on extravasation. What is extravasation? It's basically infiltration. But since chemo agents are not the same as IV fluids, which are harmless, these ones will destroy anything it touches. So therefore, if it infuses outside of the bloodstream, outside of the vein, can it cause damage? It will cause tissue necrosis. So extravasation, let me just show you a picture. So whatever drug extravasates, chemo drug, or norepinephrine, for instance, remember in sepsis and in shock, okay, we gave norepinephrine, right? We gave vasopressor. So this is what it will look like. When they extravasate, that's what it will do. See these pictures? So these are mild, and this is before the doctor debrides it, because this is just the beginning. After a while, as the drug kills the tissues underneath, this will turn black. Now the doctor has to take this patient to surgery, or this picture, for instance. So this is extravasation. Once this goes full blown, it will turn black, and then the doctor has to debride it, take out the dead tissue, and now becomes a chronic wound, which will take months to heal. That's extravasation. And that's just one example. Depends again, how long did the extravasation before you caught it? Okay, so it'll be embarrassing, right? If it occurs on your shift. Yeah? Okay, because chemo agents should not be given through a peripheral line, should be given in a central line. However, it's not uncommon. We do get orders to start it before the patient has a central line. Okay, unfortunately. We could have avoided this altogether had we used a central line. The central lines, I mean, why would a central line infiltrate, right? So what do we need to know about extravasation? You need to be able to recognize it, right? So what's the first thing we need to learn? Signs and symptoms. Okay, so let's look at the signs and symptoms. So it causes a localized inflammatory reaction. So therefore, what will be those signs and symptoms? Warm, okay. And then what will the area feel like? Well, initially, because it's still, infiltrating extravasation. Cold, okay, cold. And then later, as the inflammation extends, then it will feel hot. And what happens when you attempt to flush or assess for blood return? Will you get any? Nothing, okay? And then when you flush, there'll be some resistance indicating that the fluid is now leaking around the tissue. So these are the drugs. Again, you don't have to memorize, but be familiar with the names. Okay, so some of them, the first three are antibiotics, because antibiotics can be used to treat cancer. Okay, specifically these antibiotics can be used for chemo purposes. Nitrogen mustard, mitomycin, vinblastine, vincristine. These are two of the oldest antimetabolites in the market. We still use those today. So what's your only responsibility when you suspect extravasation? Stop. And then? Okay. Do not attempt any, warm compresses or everything. Just call your chemo nurse or call the doctor. Of course, the doctor will say, okay, have the chemo nurse handle it. All right. Any question? So what's your most important job? Recognizing it. Yeah, right. Knowing signs and symptoms, recognize it. I always get paranoid whenever I have any vesicant medications. That includes vasopressors. If I'm giving vasopressors or dopamine, for instance, infusing, I watch that IV site, especially if it's a peripheral line. I watch that not even every hour, like almost every 30 minutes, every 15 minutes, because I don't want it again to get worse. So I want to catch it early. So if there's no blood return on that IV, I'm not giving that drug for that IV line, right? Because I don't want to take the risk. I want to be responsible. So here are the drugs. There's a lot. However, since you've been exposed already to myasthenia gravis drugs, cardiac medications, vasopressors, diuretics, you know those, right? So if they don't look anything like those, like you're aware of thionamides, right? Those anti-thyroid medications. And what other medications have we talked about? We know antibiotics, right? So if they don't sound like any of those, then it has to be a chemo agent. I mean, we already talked about the anti-rejection medications, although some of them are here. Remember cyclophosphamide? This was a anti-rejection medication, right? So some of them are used for, so just look at the context of the question. What was it used for? Okay, was it used for anti-rejection or was it used for cancer? Clear? All right, so here are the names. Again, I won't test you on this table, but I will write it the same way as the NCLEX. I'll mention the drug, the chemo drug. I won't tell you what it is. Then the question follows.
Well, you just said you don't want to test on this.
Not about the drug, meaning I won't ask you, okay, what is the side effect of carboplatin? Make sense? All right. Or what is the mechanism of action of cisplatin? I won't do that. So ideally, again, we should have central lines for chemotherapy. All right, let's go straight to the side effects now. And also the bone marrow transplant, because it's mentioned here. Some of the side effects include cognitive impairment. We call it chemo brain. What is chemo brain? Patient basically has reduced IQ. Intelligence drops. This is only during the chemotherapy and shortly thereafter, maybe up to 2 years after receiving treatment, but then you regain the intelligence back. Not only intelligence, but memory is also affected here. To give you an example, so I have a friend who's very ironic. He's an oncology nurse. Now he works as telehealth, meaning his clients, his job is behind a computer. He wears a shirt, a jacket, and pajamas or underwear only. That's it. because that's all, he's on a computer, okay? It's all virtual. So he follows up on all the patients, coordinates their care, schedules, treatments, follow-ups. That's his job. And then reports to the provider. So they have clients all over. The company is called Quality Oncology. It's a great job. And who could ask for more, right? You're in your pajamas. And then it's not like you work every minute. So he goes out, gets coffee, comes back home, continues work, right? His manager, his boss is actually, he's in Orange County, California. His boss is up here in some godforsaken town in New York State. Have you heard of the place Waverly? Waverly, New York. It's near Elmira. Anyway, yeah, so it's a small town, okay? Out of nowhere. And her boss, we visited because he came here, and then we took a road trip. We stopped by his boss's home, and she runs a ice cream shop. Her husband, it's a homemade ice cream, not commercial ice cream. They make the ice cream from scratch. Yeah, it's a nice shop, big parking lot, got free ice cream.
Is that it?
Yeah.
Are you gonna get the answer?
You can drop his name. We'll see what happens. All right. Another common side effect is fatigue. Now, the fatigue here can be traced to anemia, because what will chemotherapy do to the bone marrow? Because knowing bone marrow cells, the stem cells are rapidly dividing. It's going to cause bone marrow suppression or myelosuppression. So will there be anemia?
Yeah.
Will there be fatigue? Yeah, fatigue is the number one symptom of anemia, correct? You're tired all the time, no energy, activity intolerance. However, even if there's no anemia, patients with chemo and radiation still develop fatigue anyway. For those people, there's nothing we can do because we can handle anemia, but if it can't be traced to anemia, what else can we do for that fatigue? Nothing really, except just advise the patient to rest, conserve energy. Here are the long-term complications. So not only acute, but there are chronic or long-term complications, and these are just some of them. For alteration in taste, and also you can include dry mouth there, or we call that xerostomia, is because the GI cells, especially in the mouth, rapidly dividing. Yes, so that's why the patient will also have nausea, vomiting, and then this loss of sensation here, meaning you won't enjoy food, so you won't have appetite because you can't taste anything. Plus the dry mouth, meaning when there's no saliva, all right, your salivary glands are damaged. It can also happen in radiation. So what will happen if you put a cracker or a piece of bread into your mouth? You could choke, right? Because all whatever remaining moisture in your mouth will go into that cracker or that piece of bread, which means you could aspirate. Okay? Decreased libido, dental caries also, especially for radiation. So radiation chemo kind of shares the same complications. Dental caries, obviously, if it's radiation, it destroyed the bone on the jaw. So this is for head and neck radiation. Dry mouth, again, xerostomia. Dysphagia, obviously, this is for the cancers of the mouth or pharynx, right? Dyspnea on exertion, that would be either bronchial or lung cancer. Again, specific to where is the cancer, because those will be where the tumors are located, and not only the cancer cells will be destroyed as well as the surrounding normal tissue. Because myelosuppression is our main life-threatening complication of chemotherapy and radiation, we have to ensure we minimize the effects. What are the 3 cells produced in the bone marrow? Red, white and platelets. All three are produced there. So will the patient have anemia, thrombocytopenia, neutropenia? All right. So the patient's at risk for not just fatigue, but bleeding and infection. Okay, so those are among the three. Which one do you think will be the most life-threatening? The thrombocytopenia, the anemia, or the neutropenia? The neutropenia is what will kill the patient. So we put emphasis on protecting the patient. Okay, so among the three, most life-threatening will be infection. Plus, once the patient has an infection, can we continue with chemotherapy? No, the treatment stops, and that can have disastrous consequences on the plan. Okay, we can't, so we have to start over pretty much because we have to treat the patient's infection first. Plus, what did you learn last semester? What is the most common cause of DIC? Sepsis. When these patients have an infection, can they go into sepsis? Yes. Are they among the risk, people at risk for sepsis? Yes, cancer patients, right? So therefore, the most important responsibility and intervention for nurses caring for patients either with cancer or receiving cancer treatment is protecting them from infection. So we'll skip the administration of chemo. Again, we do not give this. This is not our responsibility, but we monitor, right, during the administration because the Yannick, the chemo nurse, will not stay there. She will go back to her original floor. She's on call though. Tenzing will just call her if, but what will Tenzing see that she will cause her to report? These three here. Absence of blood return from the IV catheter. What else? Resistance, which I mentioned earlier. And then you guys said pain, burning, swelling, redness. And then as far as the temperature, it may start cold first. And then later, as the inflammation starts, there will be warm. Extravasation kit. So the Yannick will come down with extravasation kit, everything she needs, especially because the antidote is specific to the drug. That's why we won't study it because we don't know. We're not the ones responsible for giving it. Plus, each drug has a specific antidote. Does that make sense? Okay, so we won't cover that. So your main responsibility is identifying these and reporting it to Yannick. Who's Yannick? All right. And we already mentioned this, right? What's your number one responsibility after recognizing it? Stop and then call Yannick. Are we clear? Okay. So similar to, blood transfusion reaction, what did we do? We suspected the stop and call the provider, right? So same thing. So she will handle it. So, or she'll give pending instructions until she arrives. Okay, another very uncommon, unpleasant side effect of chemo related to its action, which is, again, it kills what? Rapidly dividing cells. So we already took care of the myelosuppression, which is bone marrow suppression. What is another body system that has rapidly dividing cells? The GI tract. So there will be nausea and vomiting. Now, there are three types of nausea vomiting here. There's acute. We've all experienced acute, correct? There's also delayed nausea vomiting, meaning you got chemo today, you're still nauseous 2 weeks later. All right, that's delayed. Third, there's also anticipatory nausea, meaning you haven't even received the chemo drug yet. Just thinking about it or seeing it, patient already has nausea vomiting. So how do we handle this? Do we give only one drug? We will give multiple medications. Okay. The drugs aren't listed here, so we'll have to go to the surgical chapter. So we'll come back to page 2240, 326. Let's go to the, I think it's under post-op. under nausea, vomiting.
One, four, one.
The table?
Page 441. The table.
Okay, right here. So table 16-2. You take your pick. How you decide is be familiar with the action of the medication. So you can decide, what do I use for this type of nausea? So of course you're assessing your patient. When did the nausea start? Have you given the drug already? Oh, not yet. Yannick hasn't even come. Patient's already complaining that she's nauseous. So which one will you give? Metoclopramide, prochlorperazine, promethazine, dimenhydrinate.
Yeah, we can get diamond. Hydrogenate.
So what is the key?
To prevent.
Prevent. Okay, so you look at the action. What does this drug do? This one says prevention of nausea, vomiting. This one control. So this would be for acute, right? Okay, so I'll use that for acute. This one, okay, I can use, put this patch. That's prevention. Or Zofran, ondansetron. This is for prevention as well. It's also effective because when you have motion sickness, you still have nausea anyway, right? I mean, that's the main accompanying symptom, right? I mean, you have, what do you do after this? Right? Yeah, that's what happens, right? You're on a roller coaster, then you get motion sickness, you come down. All right. So dual purpose. Any question? So I'll leave you to study table 16-2, right? So look at the action of the drug. That's the most, my favorite is this drug here, metoclopramide, because it's dual action. It not only, targets nausea, but it also stimulates peristalsis, which means, I can pass gas, I can have a bowel movement. My GI is clear, and then nausea disappears as well. Okay, because whenever you have nausea, you tend to be bloated, right? So Reglan, I love giving Reglan. I mean, I've never taken it myself, but this is what I usually ask the doctor for. Can you give me Reglan? Plus, it comes in IV form. Okay, very convenient, or IM. But if it's, let's say patient has, because usually you have on med-surg, you'll get patients who are on stage 4 cancer, and they're there for comfort measures only, meaning they're palliative. They usually don't have an IV access. So all I can give is either oral or injection or a suppository, right? So if the patient with no IV access is nauseous, is it a good idea to give an oral form?
No.
They'll just puke that out. So you're left with a suppository. So this is my favorite suppository. Compazine or prochlorperazine. Okay, very nice. Shoot it up and usually works right away. Where was I earlier? 306. That.
326, no?
What was it?
326.
26. Thank you. Okay, so that takes care of the nausea vomiting. So far we have what did we have? Extravasation. Well, we mentioned some of the, but we'll go more in detail for the bone marrow suppression. We have more. And we took care of the CINV, chemo-induced nausea vomiting. Now the questions on exam will be practical application. Okay, so I'll assess your nursing judgment on which drug to use and when you give it. So let me give you an example. So you're about to start, Yannick's about to start the chemo drug. What do? Knowing this drug will cause nausea vomiting. Okay, I can give the prevention now because is it when, if or when? It's when. I know this patient will have nausea vomiting, so I'll give them a head. Here. Okay, so let's finish the GI. So besides the nausea vomiting, the patient will also have stomatitis. What is this? These are large mouth ulcers. They don't only appear in the mouth because it's basically an ulceration of the mucous membrane. Remember, our GI tract are rapidly dividing cells, right? So they will be killed off by the chemo or radiation. So once you have these big mouth sores, they'll appear white. No, the bed will be white. They're painful, right? You've had canker sores at some point. So these are like dollar size, not even a quarter, dollar size. No, not the dollar bill, the dollar coin size mouth ulcers. Okay, ulcerations here and the tongue on the gum. Okay, really painful. So we usually give them a cocktail made of benzocaine. What is benzocaine? It's an anesthetic, right? So it's a oral anesthetic. The base solution would be saline. So it's saline with benzocaine in it, and then there's nystatin in it. Nystatin antifungal. Okay, and then there's also some other components in it, just to numb the throat or the mouth. That way the patient can eat. Okay, it doesn't hurt when they eat, because nutrition will be another problem, right? Whenever you have sores like that, you don't like to eat. I mean, it's painful. So give them those cocktails. They'll eat and then maintain nutrition. Okay, so we touched this already earlier. Let's emphasize on the drugs. Okay, so what drugs can we give to promote bone marrow function? So we have 3 colony stimulating factors here. First one is erythropoietin. Another generic would be epoietin. Similar, just take out the erythro, epoietin, okay, or EPO. Other brands besides Epogen is Ritacrit. Okay, but they're all the same. Okay, they're all erythropoietin based. So what do? They promote or stimulate red blood cell production. So it's given sub-Q once a week. I mean, it won't replace a blood transfusion, but it's better than nothing. Okay, so this can also, right here, it can reduce the need for blood transfusions if you give it religiously every week. Do we give it when the blood count drops or before the blood count drops? Before. Another is for the platelets, because the patient will have thrombocytopenia. This is your drug, Oprelvicin. This is going to promote platelet production. And then also subcutaneous injection. And then finally, it's not mentioned here, we have filgrastim. Okay, so this is the drug Neupogen or filgrastim. This will promote the growth and maturation of white blood cells. Okay, filgrastim. The Neulasta, because this is Neupogen, there's also a Neulasta. Just add PEG to the before the filgrastim. So Neulasta is PEG filgrastim. Both drugs will cause bone pain. That's the side effect. For the others, I mean, it's common sense. If you're giving epoetin alpha, what could go wrong? Say you're giving epoetin injections. What could go wrong? It stimulates red blood cell production. So what could be side effects? What if you have too much red blood cells now? Clotting would be a problem because now your cells are your blood would be very viscous, right? So too much red blood cells can cause clotting. For oprelvicin, this drug's known to cause pulmonary edema because this can cause water retention and fluid overload. So if this patient has heart failure, then watch them for fluid overload. Okay, that's the most common. So this one, blood clots, which means can they have a heart attack, a stroke? Okay, so that's why you monitor for epoetin alpha or erythropoietin. All right. And then, like I said, oprelvicin, this is known to cause fluid overload. So watch your patient's lung sounds. Okay, and then more side effects from oprelvicin are mentioned here. You got capillary leak syndrome, already mentioned pulmonary edema. Okay, it is mentioned here. Dysrhythmias, and then nausea, vomiting as well. We won't repeat renal because we already took care of AKI in 241. So the patients receiving chemo can go into AKI. Is this pre-renal, intra, or post? Intrarenal. Cardiopulmonary system, they can have cardiac toxicity, especially with these two drugs. These two antibiotics are notorious for cardiac toxicity. Now, myocarditis, that kind of thing. For reproductive system, any chemo drug, because again, they kill rapidly dividing cells. Are your eggs and your sperm rapidly dividing?
Yeah.
Yes, you have so much sperm and you make eggs every month, right? Yeah. So they will affect ovulation and of course fertility. So what can be let's say you have a young patient, 20 to 40 years of age, what will be advised to the patient prior to beginning treatment?
Store your eggs.
Okay, so bank them, right? Although have you heard the news? Texas declared embryos as children.
Yes.
What?
Yeah.
So, that could be a problem.
Store 1,000 of them. Name all of them.
At least, we're still in New York, so it's not a problem. But, it's affecting these crazy. Well, the court said so. Texas court said so.
So,
Anyway,
do we
so
explain
that's
it?
just something to think about. Okay, so it affects these people, right? It affects these patients, right? So anyway, let's move on. So we talked about chemo brain earlier, right? Nothing we can do with that. It will resolve on its own. Okay, we'll get to the hair later, because although losing your hair, is that life-threatening? Not really, but is it important? Yes, especially if a female patient, okay? Let's talk about the stem cell transplantation. I'll just describe the procedure. So what happens is the whole idea of this is for treating leukemia, lymphoma, some bone marrow cancers, bone marrow tumors. So what we'll do is we'll remove or wipe out the patient's, not really remove, we will wipe out the patient's bone marrow, kill it, and then put somebody else's stem cells or bone marrow in there. Does that make sense? Now, how will that work? How do we destroy the patient's bone marrow? Shoot it? No, we will give them high dose radiation and chemo. Now, when that happens, what will be the effect on the patient? You eradicated the patient's bone marrow. Okay, so high risk for infection. So therefore, where will this likely occur? Where will the patient be? In an ICU setting. Okay, rarely, let's say they do this in MSK, those special cancer centers. So you'll be admitted, first class, very clean room, private room, spiking you, spanking clean. All right. No, they clean it with, all the disinfectants. Okay. Really clean room. So we'll administer the cruel treatment. No? So we'll give you radiation, high dose radiation chemotherapy. And then once we determine your white counts are low, your blood counts are low, okay, we're ready. So we have to uh, make sure the bone marrow that we're putting in contains no active WBCs. So they'll carefully look at it in the microscope. Are there any active lymphocytes there? So they make sure they pick them out. Okay, no, absolutely not even single active WBC from the donor is there. So they kind of wash it. That's a term they use. They wash it and then they administer it to the patient. So it'll be transplanted, infused. And then it's all, cross fingers at that point. If the patient survives, great. So it will engraft and then replace the patient's bone marrow. Now they're cured from leukemia and then the lymphoma. However, can there be a rejection? Okay. The problem here is the patient's immunocompromised, correct? So who will reject who? Okay, so this is now possibly a graft versus host now, not acute or chronic rejection, because it's not the host rejecting the bone marrow. It's now the bone marrow killing the patient. Now, this is rare though, because what did we do again to the bone marrow before we gave it? We washed it, right? We washed it. So it only happens if, let's say, we missed something, right? We missed it. There's a few. Damn it. No, we missed a few. So those viable lymphocytes will kill the patient. So symptoms, of course, what's the largest organ of the body? Most manifestations will be on the skin. So let's see if we have a picture. Okay, so graft versus host is the opposite of rejection. So the signs and symptoms here will be on the skin. There's no picture. So this can be deadly, all right? So, okay, they didn't specify. So these are the frequent manifestations will be on the skin, the GI tract, and the liver. This will be where your manifestations will be. For the skin, which is the most common symptom and earliest symptom, I'll just show you a picture. Looks like the patient will have some, generalized, right, like that, rash like this. Okay, it's all over the body, head to toe. That's the frequent manifestation, like that. Okay, so this is GVHD. So you see that, report to the physician. That's all our expected action anyway. I mean, what else can we do? Before I leave the bone marrow, I forgot to mention a term. So that's for bone marrow transplant. They. So page 355. I'll go back to where we were earlier. I just don't want to lose this thought. Nadir, when you see this term, this is a time period. Again, it's a time period. Okay, so nadir, can you read it, John?
The nadir is lowest and following chemo or chemo?
Chemotherapy.
Chemotherapy, targeted therapy, or radiation therapy that suppresses bone marrow.
Continue. Severe
Severe
neutropenia.
neutropenia may necessitate delays of myelosuppressive therapy or treatment dose adjustments. Although the use of chemotherapeutic growth factors.
Yeah, those are the erythropoietin, the oprelvicin, filgrastim.
That reduce the severity and duration of treatment associated leukemia as well as infection related mobility.
And early death. Okay. So Nadir, have you noticed or if you know someone who received chemo or radiation that do they give it every day? How often do they give it? Once every 2 weeks, right? Sometimes once a week, once every 2 weeks, but most common is once every 2 weeks. This is because of the nadir. So what is nadir again? It's a time period. It's a time when your ANC is absolute neutrophil count. Remember HIV? How do you diagnose HIV? If your ANC is less than 500, correct? Okay, so ANC, because what's the purpose of neutrophils? They fight bacteria. So there are strongest soldiers, correct? So neutrophils. So if your absolute neutrophil count is at the lowest right here, less than 1500 or worse, less than 500, then you're completely defenseless. Okay, so you're at most risk for infection. So that's why the dosing of chemo is not every day, except oral chemo. There's oral chemo we take every day. But for IV chemo, these really strong medications, the nadir averages about 7 to 10 days. So therefore, do we give them the treatment during the nadir period? Do we give the dose during the nadir period? Yes or no?
No.
No, because what will happen to the patient if you give the dose when they're in nadir? They'll die right here. So they'll die. They'll have an early death because they'll have a massive infection. Are we clear? All right. So that's why we space out the dosing because we allow the bone marrow to recover in between treatments. And then we also give, what are those drugs again? To, promote the production of blood cells. Erythropoietin, oprelvicin, filgrastim. Okay, in between we give them. Yes.
The patient can basically take oral chemotherapy drugs themselves.
Yeah, and you can even take Colace, a whole bottle of them and then
Really?
shit yourself to death. Yeah. You want to try? But it will be a very painful death. I mean, crapping yourself. Who want to do that? Plus, it's embarrassing because you don't die right away. Plus, the smell will alert your neighbor, so they'll call and now they'll save you. Okay, what did he do? Huh? Oh, I can't answer that. We don't know. It depends on the specific type of cancer. Can be months, can be years. But it can be either oral or IV. So here's a chart for the fatigue. Meaning, mentioned earlier anemia, right? But these are non-anemia causes of fatigue. So there are other factors leading to fatigue. Body image, so this will address the hair loss. So when should you encourage them to buy the wig before or after they lose their hair? Okay, so try out, wigs that match your natural hair color so that, it doesn't look like, oh, weren't you bald yesterday? And then all of a sudden you're pretty today. Okay. So you take it ahead so that when the hair starts falling off, you can put it on, stay pretty. Yeah. Some people need to continue working. Yeah. And you don't want to spread everything. Hey, I'm on chemo. Look at my hair. I'm bald. People need their privacy. People don't need to know what you're dealing with. Infection, we've talked about infection a lot. Now, what is your number one responsibility here? So when we say neutropenic precautions, what does that entail? What do you prepare? Private room?
Yes.
Okay. Do we put any plants and animals in there? Do we
Yes, no.
okay, so no
No sick
children, yeah, under 16 visiting. Okay, no sick people. What else?
No raw fruits, no vegetables.
Okay, nothing uncooked. All right, no matter how you wash fruit, especially strawberries, can you really clean that? I mean, these things have ridges, right? So no fresh fruits or no uncooked foods. Can you bring in cheese in there or deli, sushi? Okay, so none of those. Water has to be covered. Okay, you can't have a pitcher there. Has to be all covered water. Because standing water uncovered for more than an hour starts growing bacteria. The IVs here will be as short as possible. So let's say your facility policy is an peripheral IV can stay 4 or 5 days. Do we follow the same? No, they have to be changed. Tubing. SA policies, if it's a continuous IV tubing, they can stay 72 hours. Do we follow that? No, IV tubings have to be changed daily, okay? 24 hours for everything. We monitor vital signs frequently, especially the temperature. And can they mount a normal inflammatory response? Meaning, do you wait for a 100.4 temperature? Okay, so 99 is already fever for these patients. Which body parts will you wash? Because these are weak patients. They have anemia, so they're tired, they're fatigued. Can they get up and take a shower? No. So what are the 3 body parts you have to clean every single day, twice a day actually? Mouth and the perineum. Okay. So if they're too tired to take a shower, at least promote oral care, armpits, and the perineum. They're too tired. I can't do it myself. They'll have to do it themselves. Yes, hand washing, of course. But they can use, hand sanitizer. That's fine. But mouth, we can't put a sanitizer there. So they have to brush their teeth. Although you can put hand sanitizer here too, right?
No.
Yeah, you could.
Yeah, but it's going to get sticky. Yeah. And put hand sanitizer here? So here, so for neutropenia, remember, it doesn't have to be 101. Okay, so look at the neutropenia criteria. Does it have to be 101 or 100.4? No. Okay. So don't wait.
But let's put again.
Which one?
Neutropenia doesn't have to be 101.
No, this just, telling you that if it's absolute neutrophil count less than 500, so any one-time temperature of 38 or 101, and this one, depending on but basically just keep in mind that you don't have to wait for a really high temperature, right? 99, a high 99 can be a sign of infection already. So, all right, so let's look at the emergencies now. So there are 6 life-threatening oncologic emergencies. Since they're emergencies, are they life-threatening? Will they be on the NCLEX? Yes. The first 2 we already know. Sepsis and DIC. Okay, sepsis, we did module 1. DIC, we mentioned also last semester. Okay, you had a presentation for that. Bleeding and thrombocytopenia, of course, that's life-threatening too, right? Okay, so that's number 3. Clotting, VTE, which can become a PE. And then on the next page will be the rest. Let's finish. So we have 3 there. Now we have a table here. Not that one. It's this one, table 12-13. So we had 3 on the other previous page. We had sepsis, DIC, and bleeding, correct? So here we have SVC syndrome. That's 4. 5 is spinal cord compression. 6 is hypercalcemia. 7. TLS, there are 7. TLS. Okay, so let's look at each one. So since they're emergencies, any life-threatening emergency, what 2 things do we need to know? How do you know it's occurring? Signs and symptoms. Then what's the other one? After you recognize, okay? Can you pat yourself? I knew it. I recognize it. What's the other one? What do you do? Okay, right. Because not all of these can be handled by the nurse. For instance, SVC syndrome. So what happens here, and this is specific to cancers that are in tumors in the thoracic cavity. Let's say you have a tumor inside your rib cage, either around your heart or any lymph node there or in your lung. So it's growing and compressing the superior vena cava. So if the tumor is pressing against the superior vena cava, what happens to the blood that's supposed to pass through the superior vena cava? Obstruction. So where did that blood come from? Your arms and your head. So if there is no drainage from your arms, shoulders, and your head, what are the signs and symptoms? Right here, look at column number 2. Dyspnea, cough, hoarseness, chest pain, facial swelling. Not only facial swelling, but arms and neck swelling as well. What can we do? There's nothing really a nurse can do. We call the doctor. Yeah, I mean supportive. We give oxygen, call the doctor. That's it. So they'll handle it from there. You may think it's surgery, but really no, they don't do surgery. Look at the intervention. They do anticoagulant, they do radiation and chemo. Surprising, yeah? Yeah, they don't do surgery although because it will, yeah, because now you have congestion, right? So what happens again when blood pools anywhere, somewhere? Yeah, clotting. So embolism is your problem. No. I had a ex-girlfriend that had this in Jersey. Well, I remember 2004, December, we talked, November, she was dead by December. I think, I made her laugh, on the phone, I joked around. She was talking from the ICU. Friends, we were taking turns, and my turn, she died laughing. I get, no, unless she died for a whole, laugh for a whole month. This is what she died from. She had non-Hodgkin's lymphoma. But we remain good friends, we were good friends. I was good to her, I think. Spinal cord compression. This is for the either primary or secondary tumors to the bone. Okay, obviously it metastasized or grew where? In the spine. So now this compressed anywhere, along the spine, it compressed the spinal cord. And of course, what will happen to you if your spinal cord is compressed? Okay, so you have your symptoms here, which are back pain, paralysis. You're on page 361, right? Okay, the thing is not working. So I'm on the table, and then on spinal cord compression, manifestations are back pain and radicular, neuropathic pain running down either leg, or paralysis, loss of sensation, or weakness. For this one, again, similar to SBC syndrome, nothing a nurse can do. Just report it to the doctor. They'll take it from there. Next is hypercalcemia. Where did this calcium come from? Okay, so what did that tumor do? Break down calcium from the bone. Is hypercalcemia life-threatening? Yes, especially severe. So manifestations, signs and symptoms of severe hypercalcemia. So includes confusion, seizure, decreased level of consciousness, hyperreflection, nausea, vomiting, constipation. And then treatment. How did we treat hypercalcemia? We discussed this under hyperparathyroidism. IV fluids with diuretics, right? IV fluids and diuretics. And then if needed, we give calcitonin. Okay, very good. And do we give, we monitor for calcium stones? AKI? Yeah, because you can have post-renal AKI. Do we put them on a cardiac monitor? Very good, children. Last one, tumor lysis syndrome. Unlike all the ones we mentioned, sepsis, DIC, bleeding, thrombocytopenia, SBC syndrome, superior vena cava, what is this? Spinal cord compression and hypercalcemia. This one is actually good news. Tumor lysis syndrome is good news because what's happening to the tumor? We're destroying the tumor. The treatment is working. Radiation, chemo is working. It's killing the tumor. Here, there's the evidence. They're bursting. We're killing them. However, the patient may die as well. There are two things that will be a consequence of tumor lysis syndrome, because whether a cell is normal or not, what do they all contain? Potassium. And what will every dead cell spill into the bloodstream? Uric acid. Okay, so the patient will have hyperuricemia and hyperkalemia. So these are the two problems. Patient, of course, will die from severe hyperkalemia, and they'll go into acute AKI from the hyperuricemia. You remember gout, right? Okay, so what will be the treatment for this patient? Will they receive allopurinol, colchicine? Okay. Will they receive, can they be on dialysis for the hyperkalemia? Yes, that's an option. Can we give dextrose with regular insulin IV? Do we give SPS? Do we give what is that? Was the patiromir, calcium gluconate, right? Bicarbonate. Okay, so those are the treatments for hyperkalemia, or diuretics also. That's it for cancer. Any questions?